So you can get mucus buildup and fluid buildup, and muscle start to contract around the airways. So that's why you sort of get that real tightening of the airways in asthma, because of that inflammation. And we'll go through that, how that process works in a bit. Intermittent, so on and off. People with asthma, they're not always having symptoms. They may be having an asthma attack, you know, one day, and then have no symptoms the next. And then it's certain triggers as well that cause a reaction. So it might be dust or chemicals that cause someone's airways to close up a bit, but they could be having no symptoms otherwise at other times. So airway obstruction. So this is what you're a bit worried about, is that their airways are closing up and they're not getting enough oxygen into their lungs. And that's something we'll have a little chat about when it comes to emergency situations, because I mean, oxygen, as you know, is very important to staying alive. So when they're not getting enough oxygen in, that's really, really dangerous situation you're in there. And hyperreactivity. So like in many normal people, your body's not going to react to dust, and but in people with asthma, it does happen. It's a sort of overreaction, exaggerated response to something that wouldn't necessarily cause a reaction in a healthy individual. So another quick question here: which immune cells produce antibodies? So don't worry about getting this one wrong. I know a lot of you might not have covered this yet, and maybe biology. So just have a guess, and then I'll go through the answers.
Again, would you expect this to be kind of A-level standard, or is this slightly more kind of first-year medical school stuff?
I think I remember covering a little bit of this in A-level, but I suppose obviously a lot of people may not have even picked A-level biology. It's chemistry, isn't it? It's the one you've got to have. So, but it looks like, yeah, a lot of people putting plasma B cells there.
Yeah, I'll just share the results there. So there we go.
Yeah, so that's great. 52% of you getting that one right. It is plasma B cells. They are the cells that produce antibodies. So T killer cells, they're the ones that sort of destroy those. And say you've had an infection, they destroy those infected cells or those cancer cells. T helper cells, they activate those T killer cells and activate those B cells to produce those antibodies. And the B memory cells, they stay in your body for a long time, over decades. And when you sort of come into contact with, say, a bug you've seen before, they're the ones that activate those plasma B cells to produce those antibodies down the line. So we're going to talk about how asthma actually works, and how your immune system actually sort of misfires, really, when you say exposed to, so I've used the word antigen here, but that's sort of a word for something from the outside. So maybe it's like a dust particle, something like that, that's entering your lungs. And then you get helper T cells get activated. And as I was saying before, they then go on to activate your B cells, which then will go on and divide and differentiate. So differentiate is when the cells become more specialized. So it's almost like when you have stem cells, and they will then go on to become all different types of cells, so muscle cells. This is the sort of same concept. These B cells will differentiate into plasma cells, which then go on and produce those antibodies. And then these antibodies will also help activate, along with the helper T cells, these eosinophils and mast cells. I'm not going to go through what these are at the moment, but just know that these are the cells that are going to cause that inflammation and hyperresponsiveness of the airways. They produce these chemicals. I think you might have heard of histamines, maybe. Sometimes people take antihistamines for allergies. That's what that chemical is. It causes inflammation of the airways. So this is an abnormal response. You wouldn't normally get this unless you've got asthma and you're responding to something that wouldn't necessarily cause an immune response. So I thought we'd go through a bit of anatomy just to check your understanding. It always helps to visualize what you're thinking about in terms of physiology. It always helps when you can see it. So if we go for if you can name what number 1 is.
I'll just bring up the poll question. I think it's number 5, actually, isn't it? Yeah, let me launch that. So this is number 1 first, isn't it? Okay.
Yeah.
Let's have a look. Okay, pretty much back up to 500. So I think everyone's in the poll and share the results for you.
Yeah. So that's great. Yeah, that 83% of you getting that one right is the trachea. So the esophagus, that's basically where that's the tube where your food goes down, really, goes into your stomach, and that sort of lies behind the trachea. The larynx, that's just above the trachea. So it's the same sort of pathway. That's where the air from your nose and mouth goes through, and then it ends up here. And then if we go on to number 2.
Yeah, just give me a second, I'll launch that. There we go.
Perfect, thank you.
This could be like a little bit of a trick question.
Yeah, as well. I've been a bit mean with this one.
Right, looks like we're back up to about 500, so everyone should have had time to vote.
Yeah, that's great.
I'll share the results for you.
Yeah, so that's great, everyone. Right main bronchus. I always found it really confusing at the start when right is basically left and left is basically right. You've just got to think of it as if you're looking from the point of view of the patient. So if you're looking down the body, that's on your right hand side there. So that is, yeah, the right main bronchus. So well done, guys. And then that will sort of split into those lobar and then segmental bronchi, which sort of get smaller and smaller as you go along, and then you end up with the alveoli, those big air pockets at the end where gas transfer happens. So we'll go through the symptoms. Oh, sorry.
That's definitely something that's covered at kind of A-level biology kind of level. So, you know, we would expect most people to get those kind of questions right. So it's really good to see kind of 80, 90% getting that right. It's really good. Yeah,
definitely. Well done, guys. So the symptoms now. So you've got these tightening of airways and you've got the swelling, inflammation, mucus buildup, and these are going to cause these sort of symptoms. So we've got wheezing, which is, it's quite difficult to sort of picture unless you hear it. But I'd say if you ever get the opportunity, say you see a patient or you're on your work experience and the doctor comes up and says, do you want to have a listen to this patient's chest? They've got a wheeze. I definitely recommend it. It's a really, really strange sound. So it's sort of almost musical quality to it. And when you see someone with a wheeze, that indicates narrowing of the airways. You can hear the air sort of whistling through those really tight areas. Breathlessness, as I said before, the oxygen's not getting in. You're trying to almost catch your breath. You'd see people with that almost struggling, really struggling to breathe. Some people get a tight chest as well, whether that's from maybe coughing a lot, you maybe get sort of a muscular pain, but it also could be from that inflammation and possibly getting air trapped in the lungs. And then coughing, as I said before, that inflammation, that irritation of the airways, you're going to be coughing a lot. And it's also, it would be classified as a non-productive cough. So say someone had a chest infection, you normally get a lot of green mucus coming up. It wouldn't be the case here because it's not really an infective cause. So you wouldn't really be coughing anything up with it, which is how you differentiate it from maybe like an infective cause, like say you had a pneumonia or something, which is sort of like a chest infection. So these ones highlighted in red here, these are the real emergency symptoms. This is when you know the patient's in a bad way. So use of accessory muscles. So these are like your neck muscles. So sort of the one big one coming down here, if you can see that's really strained, and they're using their shoulders, and that's when you know they're really struggling to get the oxygen in. Unable to complete sentences in one breath, that's a really bad sign, and that's how we differentiate some of the real emergency types of asthma. So we acute, severe versus moderate would use this as sort of way to differentiate between those. And then complete exhaustion, that's when you know this is a really bad situation, and you may have to ventilate the patient because they've just completely ran out of energy to use those muscles to get air in. So as I was saying before, there's so many triggers for asthma. Different people have different triggers. Two people with asthma might be, one might get an attack when they're exposed to pollen, whereas someone, you know, might have one when they're exposed to dust. So it's different for every patient. So it's important you take a really good history. And when the patient knows which triggers they have, it's really helpful in knowing when to take their medicine and when they really need to sort of watch out and prevent those attacks coming on. So how do we test for asthma? There's not really a specific test for it. It's just using the sort of symptoms that we saw before and a couple of these function tests to see how the patient's breathing. So one of these tests is the FEV1 to FVC ratio. So this kind of looks really confusing, but when you break it down, it does really make sense. So the FEV1, that's the forced expiratory volume at 1 second. So you're basically going to make the patient take a really massive breath in and then breathe out as fast and as hard as possible. And the FEV1 is how much air they get out in that first second when they're breathing out. And the FVC is the total amount of breath that they breathe out in that massive breath out. So looking at that graph here, you've got a normal person here. They got a really big FEV1, they're getting a lot of air out quickly. And then the FVC here, which is the total amount of air they can get out in their lungs. So I'd just like to see, I mean, this is a really tough question. It's the first time you've come across this, whether you could tell me which one asthma would be, whether it would be the blue line or the orange line.
Yeah, this is quite a tough question. I don't know if any students would have seen this before, but you know, we'll have a look at the poll and see what comes back. It is looking quite close at the moment.
Yeah, so it's good to come across this stuff early, because I mean, it's something that I see quite a lot, and then I still get confused by it. So when you see it early, you're like, oh, that doesn't quite make sense to me, and then you can read up on it, and then hopefully you've seen it now and you'll remember it when you get into medical school and this comes up. Cool. So
how would they measure this?
Pardon?
How would they measure this?
So it's so it's liters. So basically they'd have like a massive tube connected up to a machine, and so they take a massive breath in and then they'd blow out into the tube, and then it would measure the amount of air that the patient's expelling out of the breath.
Right, I'll just share those results so everyone can see those. So it's really close.
Really close. So yeah, really tough question, guys. But so asthma actually follows the blue line. So because it's what we call an obstructive pathology. So it means that there's something stopping the air getting out, which is why you've got a decrease in the FEV1 there, because those airways are so tight, you're not getting the air out quickly. But there's nothing actually altering the volume in their lungs. They've still got the same amount of air in there, which is why the FVC ends up being basically the same as normal. So in terms of restrictive lung disease, that it might be sort of someone with obesity, where their lungs are sort of, they can't fill up as much as a normal healthy person would, which is why the FVC will be lower. So asthma is obstructive rather than restrictive. But really tough question. It's beyond A level, but I thought it's good to maybe look at this stuff now, and then you get ahead for maybe your first year at medical school. So other investigations you want to do, if you suspect someone has asthma or maybe is struggling to breathe, then be a chest x-ray. And that's something a lot of patients will get, especially if they're coming with breathlessness. You want to exclude some real dangerous stuff. So in asthma, it should be normal, but you want to make sure there's no infection that would come up on x-ray that would have a completely different management to asthma. You want to do a full blood count. So that's where you're basically looking at the cells that make up the blood. So how many red blood cells you've got, the hemoglobin levels, and that should be normal. But that, again, you're excluding something a bit more dangerous. And as I was saying before, like those eosinophils that release those nasty chemicals that cause inflammation, they might be increased, but not always. So the pheno test, this is a new test that I recently come across, and it actually measures the inflammation in the lungs. And see, this is something that happens in medicine all the time. Like, I mean, this isn't something I was taught in my first few years. This is something that's come out quite recently. So medicine's always changing, updating. So it's really important to keep checking the guidelines and keep track of, what's going on in terms of management. And so finally, peak flow, which is a really, really important one. I'll show you this quick video here, which shows you how to do a peak flow. Oh, can you hear that? Is the volume coming up?
I can't hear it at the moment.
Okay, well, that's fine. There's subtitles, so and you can just sort of see it. So basically what she's going to do is just take a big breath in and massive breath out into the tube there. And it's similar to the test before, just seeing how much volume that they can expel from their lungs. And this is something that
we can always share the link later on as well.
Yeah.
We can share the link to that video. But I'm sure a lot of students have seen those kind of standard peak flow type devices. I think I remember doing it at GCSE level. We had some of those.
Oh, right.
We're doing those. But yeah, we'll share the link anyway, just so everyone can see that video later.
Yeah, definitely. Like, it's a really simple explanation, and it's something you're asked to explain a lot to patients, teach them how to do a peak flow, as you'll always do it at the end of your respiratory examinations, which is something that you'll do a lot in medical school. So I've got another poll question here. So here's a graph of the peak flow, normal peak flow results. If you can put the next poll question up. So we'd compare these peak flow rates to the normal values, just to see, how well they're doing with that. It might be tough because I don't know how big it will be on your guys' screens and stuff like that. So
I think you can kind of close the poll down as well to go back and look at the graph if the poll's in the way.
Okay, cool.
But yeah, we'll give them a little bit of time to work this one out as well.
Yeah.
We can see the votes are coming in slightly slower, so it's just, we'll give them an extra few seconds for this one. Was asthma something you covered? Was it first year of medical school, second year of medical school? When did it come up as a topic?
I think it was second year. So the first year was very broad sort of basics in first semester, and then we did sort of musculoskeletal system, and then second year we did sort of thorax, so we did cardio and respiratory in one semester. So I mean, you sort of cover the immunology early on, but actually in terms of management and treatment, it was a second year topic.
Right, I think we're nearly up to about 500 again. I know some people might not have been able to vote yet, so I'll give you an extra couple of seconds quickly.
Get the win, guys.
Right, okay, I'll share the results now.
Cool.
There we go.
So yeah, most of you getting that right there, 57%. Yeah, so 50% was the right answer. So a bit of it mean here, like, but I mean, reading graphs surprisingly is something that you'll do quite a lot, and you know, reading guidelines and charts and things. So if you look across here, so 160 centimeters, and she's female, so you're looking at this bottom bit here. So if you go up from 25, her normal peak flow should be around 430. So 215, you'd be around half of that. So yeah, that's great. And yeah, so if you saw a patient like that in the hospital, you'd be pretty worried with a peak flow 50% of normal.
What would you kind of think was on the brink of normal? What's the point where you're worried?
So anything maybe less than, so you compare to their baseline as well. So maybe if they've done one before, but anything less than maybe 75%, you're a bit like, oh, maybe something's wrong here. And then when it's getting to about sort of 60, 50%, you're like, yeah, okay, something really needs to be done. So I think a lot of you probably seen people taking these blue inhalers before. And so I'll go through these quickly. I won't go super in depth, but it's really interesting to know how these work. So these are beta-2 agonists, and won't go into what that means, but just know that that's what the type of drug it is. And these are like your reliever inhalers. These are give you so they relax the muscles in the airways, dilate the airways, and then basically stop you being breathless. So you might have seen people take these before exercise or during exercise, and these are sort of your instant symptom relievers. And they also stop those chemicals being released by those mast cells in that immune response that we talked about before. And you can get short-acting and long-acting inhalers. So we always call them SABAs and LABAs for short when we're talking about in medical school. So the short-acting ones, yeah, they're the ones you're going to be taking quickly when you're feeling a bit breathless, and then that instantly sort of makes the symptoms go away. And so salbutamol, that's probably the most common one you're going to see a lot of the time, always comes up. So that's a good one to sort of keep in your heads for when you start medical school. And then the long-acting ones as well, but they're sort of used later on down the line when the asthma symptoms are a bit more persistent and serious. But in emergencies, you can also give them IV, so on a drip, or you can take them orally. So if you need really quick acting dose in an emergency, these are what you're going to be using. So you're basically going to be guessing here, but I always think questions help you remember. So I thought we'd do a little poll of what we think the side effect of salbutamol is.
I think I'd be really impressed if we got the majority of people getting this right.
Yeah, definitely. Yeah, this is definitely something that you won't have covered, but as I said, it's like almost doing like flashcards and testing yourself. I always think that like once you do a question on it, it really sticks more than just reading a slide or something.
Yeah, I always find that. I think sometimes even by getting it wrong, you remember it more.
Yeah,
because you're like, oh
definitely.
my God, like maybe I should have known that, or I would have done that.
Yeah,
Whereas if you just get
and then,
the answer right, you assume that knowledge there and you just forget
just
it.
yeah, definitely. You learn from your mistakes, don't you?
Right, okay, we're back up to over 500, so I'll share the results.
So dry throat, that's definitely understandable why people have put that, and but it's actually a fine tremor. So this is something that a lot of people will get when they take salbutamol, and it's always something that we include in part of the respiratory examination. So you'd get the patient to hold their hands out like this, and you'd look from the side, and sometimes you'd see that they have a bit of a tremor, a bit of a shake, and that sort of gives you a hint that they're possibly an asthma patient who's taken a salbutamol inhaler. So that's a really good thing to remember, because it's something that is really simple, but you do miss out of the examination sometimes. You're so ready to go ahead and have a listen with the stethoscope, but looking out for that tremor, that's really important. So glucocorticoids, so these are type of steroids basically, and these are used for anti-inflammatory action. So these are much more long-term medications that prevent the asthma progressing and stop that immune response happening in the long term. So these aren't going to help when you're having an asthma attack or you're feeling a bit breathless. You're not going to want to take one of these because it's not really going to do anything in an inhaler form. You're going to be wanting to take that short-acting beta agonist that's going to relieve those symptoms. So adherence is vital. Like you patients are quite bad with taking stuff every day. So you might have to tell them sometimes that you really need to be taking this, because it's that sort of progression, that long term, taking it every day, you're improving. And then they'll probably have less attacks if they're taking this regularly. So as I was saying, that so it's usually inhaled, it's usually an inhaler, but if the asthma is really bad, they may eventually move up to taking a tablet, and in an emergency they can take it IV as well. And so beclomethasone and budesonide, they're two examples there that you want to keep an eye out for. So this is a really complicated chart of sort of how we manage asthma, starting off with just those blue inhalers, and then working your way up and adding the steroid there, maybe adding a long-acting inhaler, and then eventually that oral steroid tablet. But you can move up and down the scale. This is why patients have regular asthma review meetings, because you're not necessarily going to want to be on steroids for a long time, because they do have a lot of side effects. So you can have bone breakdown with it. You can get fungal infections in the mouth if you're taking an inhaler. So we try and keep patients off steroids as much as possible and use these other sort of medications that have fewer side effects. So just check you've been listening. Which medication are you going to use to immediately relieve asthma symptoms? So that leukotriene receptor antagonist, that's sort of another one that was on the ladder there. But yeah, it's a bit more complicated than what we'll go through today.
We'll just give it a couple more seconds. We're nearly up at 500. So we'll see how many people will get that right.
Amazing. I'm not boring you all to death yet. So yes, the SABA, that's the really important one. I think if you take away anything today, it's that you're wanting to take a short-acting beta agonist in the short term. That's that blue inhaler that you've probably seen a lot of people using. So what happens in an emergency? So acute severe asthma, this is This is a real deal, like this is life-threatening possibly. You really want to act fast. So first thing, I think you're going to want to give oxygen. As I was saying, the airways are closing and not getting enough oxygen into the lungs. You want to keep a track of there. So we track the oxygen saturation. You may have seen like a probe that they use on the finger. You want to keep that between 94 and 98%. Anything lower than that, you're going to get a bit worried. A salbutamol nebulizer, so that's the same drug we were talking about before that, short-acting beta agonist. And you can use that in a mask as well. It's sort of like a mist that is pumped into the mask, and it can also be combined with an oxygen mask as well, so you get 2 in 1 there. Ipratropium, that's another new drug, but basically the concept is just open up those airways, and that's another drug that's going to do that. And the glucocorticoids, like before, those steroids, you're going to either want a tablet or get it in on a drip. That's going to act, so it's not sort of like that long-term inhaler, it's a very fast-acting, straight into the bloodstream steroid there. Magnesium sulfate, that's in real emergencies when you're really worried. That's going to relax the smooth muscle, that relax those airways as well. So basically you're going to give them anything and everything that's going to dilate the airways and get oxygen into the lungs. And then if in doubt, always consult with your seniors. And then ICU as well. You may need to ventilate them if they're becoming exhausted, like I mentioned earlier, and they're not breathing spontaneously. You might want to put a tube down into their lungs and breathe for them. But I mean, don't be too, take too much notice of the names of the drugs. Just know that you're wanting to give them rapid doses of medication that's going to relax those airways. So I'll hand over to Mark there. That's sort of the end there before the Q&A, and he's got a competition for you guys that you can enter.
Yeah. I had completely forgotten about this, but last time we did a webinar a couple of weeks ago, I uploaded that photo to Instagram, and it did really well. And we gave 10 free clinical skills courses out for students. So it worked really well. So I just thought I'd try it again. But this time I'm going to make it a little bit different. So obviously I took what I think is quite a good photo of my workspace. So, what we'd like you to do is take a picture of your workspace. Hopefully it's as neat and tidy as mine. And then tag us, which is @medicalprojects on your Instagram. And what we'll do, anybody that does do that, I'll send them a 50% off for our UCAT crash course. I'll send you a voucher code as soon as you've done that, and like everybody can have that. I'm just intrigued to see if anybody's workspace looks as neat and tidy as mine. So yeah,
Mine's
give that a go. Yeah, I just think a lot of students will be kind of starting to prep for the UCAT as well. Obviously, there was a statement released by UCAT saying that students are going to be able to do it from home now as well. So our UCAT courses are really kicking in now, and so like 50% off one of our courses is not bad for taking a picture. So yeah,
definitely. Yeah, I would definitely recommend, guys, like it's something you really want to prep for. It's so important for your application. So getting a good start, would definitely recommend. So if we go to Q&A now, have you got any questions up?
Yeah, definitely. So as I mentioned before, we've got the upvote feature there as well. So we can see that there's some questions in there and people are already using the upvote thing. So that's really good. So we'll start at the top. This one has the most votes. So does asthma increase your risk factor to COVID-19? If so, how?
Yeah, so asthma is, I think that's a big risk of COVID-19. So I don't know if it increases your risk of actually catching it, but in terms of the health effects that it could have, definitely. So I'm not sure of the exact pathophysiology of it, but I assume it's quite similar to when someone with asthma gets a chest infection. It does tend to be much more serious than normal. So I don't know whether it's just like I don't want to go too much into it in case I don't really know the answer properly. But yeah, it's they tend to get much more ill with typical chest infections than normal.
Yeah, I think obviously like COVID has been so rapid, the amount of time to conduct research and know whether it's kind of clinically linked and things, you know, nobody really knows that yet. So, but yeah, like you say, anything that's kind of respiratory related is going to bump up that risk factor most probably. And, you know, if you've got kind of chronic asthma or something, then it's potentially a bigger risk factor for you maybe.
Yeah, definitely.
This is a good question from Hannah. How is it that people can outgrow asthma?
So yeah, I actually,
question.
this is so tough, honestly. I feel like, I mean, I just want to specify I'm not a doctor, so it's probably a good job, but I think it's probably just growing and developing the immune system. Like, I mean, it changes over time. You're exposed to different things. Potentially, the antigen might not have that exaggerated sort of effect that it did have before. But in terms of specifics, again, like, yeah, I'm not too sure on that one.
Tough questions.
Yeah.
Well, it's something we can potentially go away and research. You know, medicine isn't always about knowing all the answers, but you know, especially if you don't know the answer, it's go away and do some research and or ask somebody. You know, ask seniors. But yeah, two tough questions there. I'll throw you in. So this is a more kind of general question. Are there any books that you'd recommend reading to improve my uni applications?
So there's a few that are really common, like that I know a lot of people read, like The Man That Mistook His Wife for a Hat. But I think some of those are so common where maybe it's good to sort of try some different ones. So I know the books by Atul Gawande are really good. I think, I can't remember the name of it. I think one's called Better. But he gives a really good insight into the patient psyche and ethical stuff as well. And then there's I've recently read one about I think it's the Adam Kay books. I read Twas the Night Shift Before Christmas. That was a really good book. I think it gives you a really realistic insight into medicine. It's not all saving lives. That you do come across some really strange stuff, and it's like really a funny book as well. So yeah, I would definitely recommend those. And just reading articles as well. Like any of the articles we've got on the website are really good. And then just maybe reading the research around COVID-19 at the moment, just so that you're aware of what's happening in the world. Would recommend that.
Yeah, definitely. The last webinar we did was about kind of work experience and insight, and we did like a full section about articles to go and read and books to go and read. I think there's like 12, 15 different books. So if you look at that webinar, the recording's on the website as well, and the slides are on the website if you just want to go straight to the slides. And there's a stack of books there for you. Right, okay, let's have a look for another question. Is asthma hereditary?
There possibly, I don't think so. I don't think it's like a autosomal dominant, like it's not one of those things where you could make, one of those trees. I think there possibly is genetics involved, but I wouldn't say that it was hereditary. It probably is just more likely to occur in families.
Have you ever heard of asthma being stress related is one of these questions?
Yeah, so that is one of the triggers. I think it was on the slide before. So basically, today we've gone through sort of allergic type asthma, so when you get an antigen coming in, but there are other types that are a bit rarer. So stress is one of them. So that can cause an increase in inflammation, and then eventually lead to those asthma symptoms. So yeah, that is one as well, and sort of anger as well can be one. I think like really strong emotional situations can cause asthma. So yeah, that's a really good question.
And this is kind of related to exercise as well. So I have exercise-induced asthma. How does exercise trigger the asthma?
So I wouldn't know specifically. So potentially it's almost similar to maybe the stress induced one, where you're putting a lot more effort in and stress on the respiratory system. Potentially that's why it causes it. But in terms of like the underlying cause of exercise induced asthma, I'm not too sure, to be honest.
And we've got quite a few people asking whether it can be kind of cured or whether it can only be controlled.
Yeah, so obviously other than children outgrowing it, in terms of adult asthma, I haven't really heard anything about it being cured, but some people do have it much milder than others, and using those steroids, the glucocorticoids, regularly and keeping it under control. Some people may never have an attack if they take it regularly. So yeah, it's controlled but not necessarily cured.
Okay, cool. Let's see if there's any more towards the top. Do certain ethnic minorities have a predisposition to asthma? These are really difficult questions, aren't they?
Because the thing is, I feel like medical school, you get the real basics down, but this sort of stuff is very specialist. Like I'd probably ask a few respiratory trainees, and maybe they wouldn't even know. So, but potentially, I wouldn't know specifically. Like it is true that certain ethnic minorities have different predispositions to different diseases, like people of South Asian origin are more likely to get diabetes. So it is a possibility, but yeah, I'm not sure at the moment.
And this is currently the top rated one. Again, it's really specific.
Mm-hmm.
Why is it that premature babies have higher rates of asthma?
Again, but I mean, possibly because their immune system maybe hasn't matured as much as, say, a baby that's been, carried to term. You get crossing of antibodies from the placenta to the baby, potentially something to do with that. Maybe they are more sensitive to certain antigens, but specifically, yeah, not sure on that one.
And could it be down to kind of the development stage of the lungs as well, if they're premature?
Yeah, definitely, possibly. Yeah, so they may not be, that sort of muscular structure. Yeah, potentially might not be fully working yet.
Okay, I'll scroll down to try and get some of the questions towards the kind of middle and bottom as well. So Amber was asking about the colour of the inhalers. Does the colour matter? I guess it does matter because they're different things, aren't they?
Yeah, so the colour is linked to what type of drug it is. So normally those short-acting beta agonists, there'll be a blue inhaler, and then those steroids will be a purple inhaler. So it's just sort of because I think, if you're an asthma sufferer, you might have, both of those in your bag. You don't want to be taking the wrong one. So it's just an easy identification, I think, of which one you're taking.
Okay, and then someone has asked, why is the male PEF so much higher than women's?
I think it's just sort of those physiological differences between men and women. Like men just tend to be, a bit stronger, have a higher lung capacity. So it just is, easy for them to, have a higher peak expiratory flow rate. So it's just the way we're built, really.
This is quite a good question as well. Let me just see if I can find it again. It keeps changing. But it was essentially about if you saw someone having an asthma attack, what should you do as a bystander? Obviously, if you've got no medical equipment, nothing with you, you're just out in the public, what would you kind of do in a situation like that?
Yeah, so it's something that we've never really been taught about, but I suppose it depends whether you knew they had asthma specifically. There's a lot of things that can cause breathlessness. So I think unless you know it's asthma for certain, then I think, be cautious. They might have an inhaler lying about somewhere. They might have an inhaler in their bag. Find that for them. But other than that, I think just ringing an ambulance, because there's only so much you can do as a bystander, really, other than finding their medication and calling for help. It's the first thing you do at learning BLS is you just need to call for help, because you can't really deal with everything by yourself with no equipment. So it's just acting fast and getting that ambulance along as quick as possible.
We'll take another couple. We're coming up to an hour now, so we'll take maybe 1-2 more questions, and then we'll kind of wrap it up, so we're not kind of running on into everybody's evenings. Would an asthma-related EPQ be good? If so, do you recommend any aspects of asthma to do an EPQ on?
Yeah, EPQ is a great thing to do. I really enjoyed mine. I did mine on medical ethics, and it's something really interesting. So it might be really good to do something on maybe the emergency management of it. And maybe the testing of it. That's something that's changing with the new pheno testing and diagnosis of it. And potentially like the maybe the magnesium sulfate. That's a really interesting thing, because it's not necessarily a medication that you've really thought about as, a drug, but maybe how that works and how they work in combination with those inhalers for the emergency treatment. That could be really interesting. But doing asthma is a really, really good idea. Something medical that you can talk about in an interview. Definitely really good.
Okay, I know we've still got lots and lots of questions there, and I'm really sorry that we haven't been able to kind of answer everybody's questions. There's one more here. We'll do this as the last one. Mm-hmm. We do have more webinars coming up as well, so kind of sign up for those and post questions on the next ones as well if you can. Last question here. Can you explain the difference between obstructive and restrictive?
Okay, so obstructive. It's basically where if you're trying to expel air out, there's something blocking it. So like asthma, your airways are tightening up. You might have a tumor maybe in your bronchus or in your trachea that's blocking the air getting out. Whereas restrictive, that's basically something that's almost restricting your lungs. So say it's obesity, You might not be able to inflate your lungs as much as a healthy person. You might have maybe a neurodegenerative disorder, so motor neuron disease. You're not going to be able to inflate your lungs as much as possible because you're not going to be strong enough. So yeah, that's something that is really good to remember, the difference between the two of those, because it's something that does come up quite a lot, and knowing examples of each. But that's sort of the basic gist of it.
Okay, thank you very much. Yeah, sorry we can't kind of get through everybody's questions, but we've got kind of like 130 questions. We'll be here until like kind of 1 a.m. So I'm sorry if we haven't managed to kind of answer your questions, but we will try, and if you join us on more webinars, we will try and answer as many questions as we can. Yeah, thank you very much for joining us. Thanks, Minnie, again for doing another webinar with us. We really appreciate it.
Yeah, thanks for having me.
Again, your knowledge is amazing. Yeah, more webinars on the website. Go and have a look, and we'll send the slides out in the next kind of 48 hours as well. So I hope you enjoyed it. Leave us some feedback as well, and then we'll see you again soon. Thank you very much.
Thanks, everyone.